Great. Thank you so much, Vivek, and thank you for the opportunity to join the Training Institute. Thank you, Pedja, for the opportunity as well to co-present with you. So I'm going to kick it off today and then hand it over to Pedja. And I think that we can, happy to take questions throughout. If there are questions in the chat, I won't be able to monitor that, but feel free to just interrupt. Otherwise, I think perhaps we can wait until both of us present and then perhaps have discussion afterwards. But Pedja, I'll take your direction on that front. So the plan is for me to just set up some brief background on implementation science. Admittedly, a very brief introduction to the broader field. And I'm going to talk about some of our work to identify and classify implementation strategies and sort of future directions there. And then spend a bit of time talking about how we can more thoughtfully design and tailor implementation strategies and some considerations for evaluating implementation strategies, particularly with respect to specifying and testing mechanisms of implementation strategies, which Pedja will very much take up in his subsequent talk. So to begin with, I think we all are aware and can acknowledge that there's a growing body of evidence for a lot of different types of interventions. Sometimes in implementation science, we refer to these as the 7 Ps, and not meant to be rigid categories here, but we can think about programs, practices, principles, procedures, products, pills, and policies that we have a growing body of evidence, things that we would like to see implemented in real-world settings for the benefit of population health, but we know often that these things are not implemented well. While we would like to see this movement from bench research to bedside benefit and population benefit, we often see rather the transition from bench to bookshelf, that either these interventions are not used and sit on the shelf, or are used poorly, perhaps without fidelity, and therefore we see what we might refer to as the voltage drop, where interventions are not as effective as they are scaled up and sustained. So this leads to persistent gaps in quality. Many of these reports are old, but some of these are key reports from the Institute of Medicine or the National Academies for Sciences, Engineering, and Medicine that document quality gaps both domestically and globally. And I think probably in this room, we have folks with a lot of varied interests and probably a keen sense of where the quality gaps are in your area that you're striving to address, largely through mHealth applications here. So there's an acknowledgement that evidence-based practice really needs to be complemented by evidence-based implementation, and there's an increasing focus on developing evidence for evidence-based implementation strategies, and really understanding implementation determinants and processes better. So the emergence of the field of implementation science, though many argue this is an older field, really the first issue of our key journal in the field, Implementation Science, was put out in 2006, so a relatively young field, and they've defined it as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. And they note that it includes the study of influences on professional and organizational behavior. And I think as the field evolves, we move beyond just professional and organizational behavior and really think even about patient or end user related determinants or barriers and facilitators to evidence-based practice, as well as systemic policy level, financial level factors that may influence the implementation of evidence-based practices. And obviously this definition keys in on the methods or the implementation strategies that we might use to implement effective practices, which is going to be a key tenet of our talks today. Just to give you a bit of a contrast between how we might think of implementation science in comparison to efficacy and effectiveness research. In effectiveness research, we often have a primary focus on the intervention and perhaps on evaluating health outcomes or other distal outcomes of interest, whereas the system to support adoption and delivery with fidelity is often fading into the background and less emphasized. Whereas in implementation science, this really is foregrounded. And so we have a primary focus on the system to support adoption delivery with fidelity, oftentimes evaluating things like the quality, quantity, and speed of delivery. whereas we may still have a focus on evaluating health outcomes. I know Billy in her last talk emphasized hybrid effectiveness implementation designs, where we maybe have a dual focus on both testing the effectiveness of an implementation strategy, whereas we also have a focus on evaluating health outcomes. Oftentimes, the focus on the intervention and clinical outcomes in implementation science is a bit in the background. Just a couple more sort of models that might help us think about this. Again, this is including efficacy research in highly controlled settings that are really asking sort of fundamental questions about, could an intervention work under ideal circumstances? As we shift to effectiveness research, hopefully in more pragmatic, with more pragmatic features in community settings, we're asking questions like, does an intervention actually work in real world settings? And as we shift towards implementation, there's really a focus on making an intervention work and considering, barriers and facilitators and necessary strategies and supports at the, phases of implementation that are really focusing on, exploring potential evidence-based practices and implementation factors, preparing to implement a given innovation, and then hopefully implementing, sustaining, and scaling a practice over time. Many of you have probably seen this model. This is a basic conceptual model of implementation research developed by Nola Proctor and colleagues, and also have references for her work referencing implementation outcomes. But what you see here is essentially that we have two different types of interventions on the left. So you can think of the what, or these are sort of the 7 Ps that I emphasized on the previous slide: quality improvement interventions, evidence-supported treatments, and the like. Whereas we also are focused on a different set of implementations of interventions in our implementation strategies that really describe the how effective practices are moved into routine care. This model also emphasizes, I think, critically, a different set of outcomes. And so, again, in our sort of efficacy and effectiveness research, we may be focused on these most distal outcomes. In implementation science, we're often focused on are the interventions and or the implementation strategies that we're investigating acceptable, feasible, and appropriate for various settings and implementing partners? Can we implement them with fidelity? Can we evaluate things like the cost of implementation? And ultimately, can we ensure that they are spread across settings of interest and hopefully sustained and scaled? So really a heavy focus on these intermediate outcomes that are essential in achieving our desired patient and more distal outcomes. So moving ahead quickly, I know to implementation strategies, we've defined implementation strategies as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program or practice. And I don't want you to get caught up on this next piece, but oftentimes in our work, we refer to discrete strategies that may involve a single action or process. So things like clinical reminders in an EMR, audit and feedback, where we may measure providers or others' performance and feed it back to them in comparison often to their peers, or clinical supervision in mental health we can think of as discrete strategies or single component strategies. Oftentimes, given the fact that in implementation we're facing a variety of barriers and challenges related to implementation, we oftentimes are using multifaceted strategies, oftentimes that are even multi-level. So you may see these referred to as again, multifaceted strategies or implementation interventions, but essentially this is just a combination of intervention components or implementation strategy components that are hopefully bundled together in a sensible way. So there's a lot of confusion with terminology in implementation science. This is built on some work that we started way back in and published way back in 2012, and then have since updated and refined this work through something called the Expert Recommendations for Implementing Change project. So the ERIC compilation is depicted here in 9 broad categories, but this is a compilation of 73 discrete implementation strategies. I won't go over these, but the idea here is that these are strategies that you could consider as sort of the building blocks of multifaceted and multi-level strategies. Some of these I already mentioned, like audit and feedback and clinical supervision. But you can see from these categories that they're quite broad. So some of them focusing on things like financing the implementation effort, some focused on really, policy and sort of outer setting level factors, whereas some are pretty squarely focused on training and educating providers or even the patient level. So you can take a look at this compilation in depth if you like. I would point you to additional file 6 down here of that publication for perhaps the most comprehensive listing detailing those strategies. But the idea is that this hopefully provides a common language as you communicate about your implementation projects in the literature, and hopefully it does at least play some small part in improving reporting in the implementation science literature, which has been a huge problem. Just to give you some concrete additional examples of discrete strategies, and to suggest perhaps the obvious, that what we would like is for our implementation strategies to be squarely aligned with the challenges that we're facing and our goals for implementation. So this is far too simple, but if we have a lack of knowledge, it might be that interactive education sessions is a sensible approach. If there is a perception reality mismatch, so for instance, if we have clinicians who say, hey, we're already doing evidence-based practice, thank you very much, it may be that auditing their performance or auditing fidelity to a given practice and feeding it back to them in comparison to their peers is an effective strategy. If we have lack of motivation to implement evidence-based practices, it may be that some sort of financial or non-financial incentive, such as an enhanced rate for delivering an evidence-based practice, could be effective. And if we have poor attitudes about an evidence-based practice, oftentimes we see the use of interpersonal influence through an innovation champion or an opinion leader in a given setting. As I mentioned, we're often, putting multifaceted strategies together. So this is building off some work by Brian Weiner, who I see the reference isn't listed here, but Brian has a nice paper called In Search of Synergy in the Journal of the National Cancer Institute. And this is work by Sam Schilling, who is a child abuse pediatrician at the University of North Carolina. And essentially she had a evidence-based child maltreatment prevention intervention that she was trying to implement in primary care. She was noticing that actually referrals to this intervention were a major sort of stumbling block in getting this intervention out there. And so the green oval here is actually sort of our, even though it's not sort of a standard implementation outcome, this was our outcome of interest primarily. What you see in the rectangular boxes you can think of as implementation strategies. And Sam is using a variety of approaches to sort of put these implementation strategies together in a synergistic way. So she had public recognition, wherein she sort of engaged physicians in a bit of a competition, rewarding them with a nominal Starbucks gift certificate or something like that, to spur on some sort of healthy competition in terms of referral rates. She also utilized parent narratives, wherein she had parents who have gone through this evidence-based intervention to provide some testimonials demonstrating their appreciation for it. She also, and so she proposed that these two strategies would work in an accumulative fashion to hopefully influence clinician motivation. She also used audit and feedback, whereas she measured their performance and fed it back to them in comparison to peers to hopefully amplify the effect of these two interventions on clinician motivation. She also prepared parents to be active participants. So by pushing out a MyChart notification to parents about the intervention and educating them about that, hopefully increasing parent motivation, and proposing that clinician motivation and parent motivation would converge, hopefully to improve parent-clinician interaction. And then finally, she had an EMR reminder that would hopefully facilitate the effect of these strategies on referrals to PRICARE, this evidence-based intervention. And this was really, this wasn't an RCT. This was based on a simple sort of quality improvement design. But she was able to show that referrals increased from 13% to 59% using this implementation strategy. The other thing I would point you to, if you have a chance to take a look at this article, is Sam does a really nice job of describing how the implementation strategy was justified. Each component was justified using the evidence, theory, and also implementing partner or stakeholder input. So nice example of that there. I won't go into depth here, but just wanted to point out work from Andrea Graham and colleagues at Northwestern and elsewhere, where she built off of the expert recommendations for implementing change compilation that I mentioned on a previous slide, and was considering, in particular, implementation strategies for digital mental health interventions in healthcare settings. And so she, in this paper in American Psychologist, discussed a lot of common barriers and facilitators for implementing these types of interventions, and also proposed some strategies at both the exploration, preparation, implementation, and sustainment phases. So thought this would be particularly relevant to this crew in case you have a chance to take a look. So as the field has progressed and as we've learned more about implementation strategies and identified a range of strategies, there have also been concerns about a number of potential pitfalls as we think about implementing new programs and practices. One of these is that we far too often use what we might think of as the train and pray approach, or the train and hope approach, right? We send people to trainings, we kind of hope that their behavior will change and that will be sufficient. But what we know from the literature is oftentimes this is necessary, but not often sufficient. Oftentimes there are more than just knowledge gaps that can be addressed through additional training. We also see challenges related to sort of organizational and system inertia. So many of you may have been in systems where you hear sort of, we've always done it this way. We've always used these types of implementation strategies. Even if you move beyond training, sometimes organizations get rather stuck in how they approach implementation challenges. We also see what might be referred to as the kitchen sink approach, this notion that more is better and more intensive implementation strategies will be more effective, when in fact the literature has suggested that simply adding components to implementation strategies doesn't necessarily make them more effective, which is a bit counterintuitive in some ways, given that we do face a lot of different barriers and challenges to implementation. But there are, a few reasons for this, potentially. One is that a multifaceted strategy may just simply be poorly matched to the barriers that we're facing in a given setting. Another is that sort of similarly, a multifaceted strategy may be sort of still focused at one level. So we may have a strategy that focuses pretty squarely on provider behavior and provider level factors, potentially neglecting organizational system factors or patient level factors, for example. And then I'll just mention that there's increasing concern in the field of implementation science that many of the strategies we're developing are too intensive, too clunky, too expensive, and not pragmatic enough. So potentially concerns with that as well. This one is arguable based on the evidence, but one might argue that we too often use a one-size-fits-all approach. And so delighted to have Billy's presentation an example of adaptive approaches to interventions and potentially implementation strategies as well. But I think there's a lot of exciting work in the field to think about how do we better tailor implementation strategies to the needs of individuals, teams, organizations, systems, and so on. And then this is one of the founders of the field, Martin Eccles, who said, far too often we use the Islagiad approach. It seemed like a good idea at the time, right? So we're not necessarily systematically thinking about implementation strategies, nor using evidence theory and sort of pragmatic considerations to select implementation strategies. So this leads to this notion oftentimes that there's little association between the types of problems that we're facing in implementation and the types of implementation strategies that we're using to address them. And oftentimes, as I mentioned, organizational and system-related problems tend to be ignored, in favor of individual educational and psychological approaches. So this is sort of broadly potentially a challenge for the field. So we think there are a number of potential priorities for enhancing the impact of implementation strategies and hopefully moving the needle on population health. And I'm just going to emphasize a few today, and Pedja is going to really focus in on the second one here. But we've noted that we really need to enhance methods for designing and tailoring. So making explicit how we're actually designing implementation strategies and tailoring them. That we need to explicitly specify and test mechanisms of change in this space, and that we need to improve tracking and reporting of implementation strategies. I mentioned reporting challenges, and I'll just briefly highlight that again towards the end of the presentation. Certainly, there's a need for more effectiveness research in this implementation strategy space, and an increase in economic evaluations, but won't have time to cover that today. So I think this will be quite familiar to anyone who's developed interventions. These are really just sort of basic steps for developing theory-informed interventions or implementation strategies. But this is sort of, I think, something that cuts across the different systematic approaches to designing and tailoring implementation strategies. The first is just simply identifying who needs to do what differently in order for implementation to be improved. So thinking about what partners need to be at the table, what types of multi-level behavior changes are needed. And I note here at the bottom, not meaning to sort of mention this in a cursory way, but really considering equity at each of these steps, thinking about who needs to be at the table, who is impacted by implementation, who has a key role in influencing the implementation process and outcomes, and hopefully using participatory approaches to engage them. The second step here is really using informal and formal theories and frameworks to identify barriers and facilitators that need to be addressed. And hopefully, as again, Pedja will get into more, articulating a pathway of change for the targeted behavior change to occur. And I'll just note here that a variety of methods can be used here, qualitative, quantitative, and mixed methods, and also that implementation science has developed a number of frameworks that can be helpful in identifying implementation determinants. If you've gotten into that space at all, oftentimes people are overwhelmed by the number of theories and frameworks, but there are a lot of helpful resources to sort of wade through that and I think apply those to good effect. The third step is really selecting implementation strategies, and this includes behavior change techniques that might be quite familiar to this group, that may be effective, relevant, acceptable, and feasible to overcome the identified barriers and address facilitators to change. And then finally, deciding how implementation can be robustly and feasibly measured. So thinking about all of the factors along the hypothesized pathway, as well as appropriate implementation outcomes, like I mentioned before. And again, I think I won't dwell on this slide, but this is from a colleague, Shobha Ramanandan at Harvard, who's done a great service in providing this paper in annual review of public health to emphasize the role and importance of participatory implementation science approaches at each of these phases of implementation, sort of how we might consider implementation determinants or barriers and facilitators, how we might use participatory approaches to co-design or adapt implementation strategies, identify relevant mechanisms and outcomes. And so a really nice paper, and would urge you to check that out if you have interest. I also won't dwell on this slide for very long, but just want to suggest that in implementation science, there are a number of systematic approaches that have either been taken from other fields or have been developed specific to implementation to think about what are the processes and steps we need to go through to systematically design and tailor implementation strategies. So some of these that we identified on the left really were from other spaces: concept mapping, group model building, from system science, intervention mapping or implementation mapping as it's been rebranded for the implementation science space, and conjoint analysis. And then Heather Cahoon in this paper has identified a number of additional methods. And I'm just going to give a couple examples of those methods that you can read further about and potentially use in your work if you're not familiar with and already using these approaches. The first is intervention mapping or implementation mapping, which, if you're familiar with this, this is a long-standing method in public health, which is really a systematic intervention development protocol. It's always included implementation strategies and implementation as part of that, but it's recently been built out a lot to include implementation mapping and really trying to integrate the implementation science literature here. I won't go over these steps as I think they're quite familiar with the approach to developing theoretically informed implementation strategies that I shared previously. But I'll note that we've used implementation mapping in a variety of different ways in our work. So in the paper in the middle here, we use this actually to co-create implementation strategies with organizational leaders and clinicians in mental health. So basically, going through this implementation mapping process to develop implementation strategies that hopefully are well matched to individual organizations' strengths and needs. We've also used it within the context of a number of sort of R01 level cluster randomized trials of implementation strategies, where we are oftentimes coming into a trial with some idea of what the implementation strategy will be, but sometimes there's a need for a bit of formative work to either refine or even develop an implementation strategy. And so we've used implementation mapping as a systematic approach to do that within trials, and have found that to be a useful way of assuring reviewers that we have a systematic process as we develop implementation strategies within the context of that research. This is a quite similar approach that Jeff Curran and colleagues have used, and this is a paper from Terrence Swindle that documents the evidence-based quality improvement approach. It's another sort of stepwise approach to developing implementation strategies. And the reason why I included this as an example, and I include some other examples below of additional systematic approaches, the reason why I wanted to show this is I think Terran and colleagues do a really nice job with this table 2 here. Where they show both these broad steps of the process, but also a number of examples of how these steps can be carried out with different methods and activities. I think of varying levels of rigor, and potentially, some may be better or worse suited for your particular situation and implementing partners. And so wanted to provide that so you can take a further look at some of these methods. Also would want to emphasize here that I think this is an important area for implementation science, that we become more explicit about how we're developing and tailoring implementation strategies, and a lot of room for improving the methodological rigor and transparency here. And so would also encourage you to innovate here, and not be afraid to sort of push against existing methods, as I think a lot of them are still quite broad and in need of further operationalization. So just a few more slides here, and Pedja, again, will talk much more about this, but the initial phases of the field, there were a lot of questions about sort of, do implementation strategies work or not? And increasingly, there's a shifting focus towards mechanisms of implementation, or how and why implementation strategies work. Again, what we would like to see is hopefully, as we design implementation strategies, a relatively tight connection between the types of determinants we're addressing, the strategies we're using, and the implementation outcomes that we would like to achieve. And hopefully we're doing a better job of articulating the potential mechanisms through which these strategies are working. So I won't read all of these for the sake of time. But again, if we have something like a provider skill deficit, it may be that training and teaching in practice with corrective feedback would be an effective implementation strategy that would work through skill acquisition, refinement, and mastery, hopefully to improve something like fidelity to an evidence-based practice. And on a slightly different level, turnover is obviously a huge problem in healthcare and mental health. If we use something like train the trainer approach to ensure that real-time training and consultation is available at a local level, we might increase an implementation outcome like sustainment or sustainability. So ideally, we're specifying and evaluating these mechanisms and ensuring that our strategies are thoughtfully designed in this way. Just a quick example of the importance of this. This is taken from a paper in PLOS Medicine, where we actually were responding and admittedly doing a bit of Monday morning quarterbacking, which is probably always dangerous. But this is from a trial that had null findings from a test of a knowledge brokering implementation strategy that was meant to improve evidence-based staffing in a hospital setting. And what I want to point out here is not that this is a perfect sort of map of the mechanisms, but this is using a sort of a DAG approach, or directed acyclic graph approach, to mapping the mechanisms of knowledge brokering. And we suggested from the author's own process evaluation work and from the literature that knowledge brokers, work partly through cultivating a social link. There's a relational development component wherein they then provide brokered knowledge, so packaging, simplifying, contextualizing evidence for hospital managers in this case, ultimately, achieving a bunch of, several intermediate outcomes here that lead to evidence-based staffing. But one of the things that this, or two things that this does: one, it suggests a more specific process through which this strategy works, and points out, some things that we may want to measure and ensure are in place as we conduct a test of an implementation strategy. It also suggests contextual elements that we might want to measure or pay attention to. Oftentimes we have a long list of potential barriers and facilitators at the contextual level, and it's not clear where we want to focus. In this case, for instance, the status of the brokers and the positioning of the brokers within the organization is important. So we may want to either measure that, or as we operationalize the implementation strategy, ensure that the knowledge brokers that we're using have the sort of relational purchase necessary to influence hospital managers. And I think in this case, the study actually used postdocs and perhaps folks that didn't necessarily have that relational link to hospital managers, and potentially that could have explained partly why the intervention was not effective. Pedja will go into more detail here, but just want to point out work that he's really played a key role in leading, including a hot off the press paper using a causal pathway diagramming approach to map mechanisms of implementation strategies. And so excited to learn from him in the next portion here. And then just as I conclude, I want to suggest again that there's a huge challenge in the field of implementation science with respect to specifying, tracking and reporting implementation strategies. And as we think about mapping mechanisms and being explicit about the mechanisms through which strategies work, that actually forces us to concretely operationalize the strategies in a way that addresses this. But thus far in the field, poor tracking, specification, and reporting has really limited replication in science and practice, and oftentimes precluded answers to how and why implementation strategies work. And so we often are suggesting that people really carefully specify implementation strategies. This is work led by Enola Proctor, where she suggests people name implementation strategies using language that is hopefully consistent with the literature. This is one space in which taxonomies such as the ERIC compilation, the behavior change technique compilation, and others have helped standardize language here. But that we would also ask that people operationally define strategies and then specify them according to these dimensions. So, who are the actors involved? What are the specific actions that they're taking? What is the action target, which gets a bit into the mechanisms through which the strategy works? Is there anything about temporality or dose that needs to be specified? And then what are the implementation outcomes or other intermediate outcomes and distal outcomes that need to be mapped out here? And then finally, what's the empirical, theoretical, and pragmatic justification for why the strategy works? We know also that strategies are likely to change as new challenges emerge, as there are changes in the context. This is, almost constant in the type of work that we do. And so We also suggest that people are carefully, as they're describing plan strategies in detail and specifying mechanisms and the like, we also ask that they track strategy use over time, and as barriers and facilitators are monitored. Potentially, this suggests modifications to strategies. It might suggest some strategies are dropped or additional strategies are added, and so we just suggest that there are a variety of methods for tracking that over time, many of which are listed below. This remains a challenge for the field in terms of how do we do this pragmatically, and also how do we account for this in our designs and research methods as we evaluate implementation strategies. Won't dwell on any of these, but wanted to leave you these in the slides with, I think, some nice resources on trial designs and other research designs for evaluating implementation strategies that I would urge you to take a look at. And hopefully we have plenty of time for discussion. Sorry if I went over, Pedja, but thank you so much for your time and attention, and glad to connect after this session or after today if it's helpful to connect with anyone. So thanks so much.
That was awesome. Do you guys want to ask any questions now, or should we just jump into the second part and just then have a sort of discussion at the end? Vivek, do you have any preference?
I think probably towards the end they can assimilate. Implementation science is a little, your digital work will kind of bring it into context. And
all right. So what I'm going to do, and let me see if I can just get this up and running. All right, that seems okay, right? Everyone is able to see that.
Yes.
So Byron did an amazing job in sort of basically reviewing the field in about 35 minutes. And so what I'm going to do now is jump a little bit deeper into some of the methods that we have been developing recently around how to improve implementation, and in particular by specifying the mechanisms of implementation strategies. And at the very end, I'll sort of briefly touch on the fact that we're actually using some of these same methods to better understand how design of mobile health interventions work as well. And I have some references of where we can go for more information on that. But really, and this is a slide that I stole from Kara Lewis, our colleague Kara Lewis. So to some of the problems that Byron alluded to that we're trying to deal with is that in spite of all of these developments in implementation of science, often implementation efforts still fail. Nearly, some of the statistics indicate that nearly half of them do not have health outcomes that are actually intended. And with each passing year, the complexity and the cost of implementation initiatives tend to go up, as well as that we're starting to see that they also contribute to inequalities. And so the question now is, why is this the case? And Byron alluded to a number of reasons, including the fact that there are a lot of strategies that one is able to choose from. So ERIC itself has 73, but other strategies are available as well. And that these strategies are often misaligned with barriers. So when you actually put it together, we often know that they don't have the kind of outcomes that we want them to have. And this is stealing from Byron's talk. Sort of a way to summarize all of this is that often basically we have this misalignment between what implementation initiatives are doing and the actual problems in a particular clinical context that they're trying to address. So what I want to do in the rest of this talk is suggest that really thinking carefully about the mechanisms of implementation, through which implementation strategies work. We can actually try to deal with these problems and address this mismatch that often happens between implementation initiatives and the problems that they're trying to address. And what I wanted to offer is a very practical tool that we might be able to use to do this thinking about mechanisms. But before I jump into that, I want to give you sort of a sense of what we actually mean by mechanisms and how to think about that. And given that for many of us, it's sort of lunchtime or breakfast time, let's start with the example of toast, because everyone loves toast. And so let's say you're actually trying to make toast. Maybe you have your heart set on eating some tasty avocado toast, but you realize that your toaster broke, right? The question becomes, how else can you make toast? And so one way to think about this problem is to really try to think about, like, what is toast actually doing to bread to create toast, right? And so really, when we start thinking about that, like, what is the process that is happening when a particular intervention, in this case toasting, is applied to a setting, right? In this case, bread. We start really trying to understand what are the other options that are available to produce the same results. And so maybe your first hypothesis in the case of toasting is that really the mechanism that is at play here is heat, that you just need to apply heat and then the bread will transition into toast. Well, if you have that, you might be able to throw a piece of bread into boiling water, which is pretty hot. And of course, as you would expect, you are not going to get the results that you expected, right? And so you might go back and revise your hypothesis and say, really, it's really dry heat. Maybe that's the mechanism that is at play here. So you put your piece of bread on a plate. Maybe it's summertime, you put it in front of your house, and it might take a long time before you get toast. So this is not exactly the right mechanism, apparently, either. And so your third reaction, variation on this might be that actually what the mechanism that is at play here is that it's a heat transfer via contact with a very hot surface, right? And so another way you can do that is, of course, put bread into the oven, and maybe you do that, and of course you get toast. And then you end up with a wonderful avocado toast and everyone is happy, right? And so the question here is, what did we learn, right? And so the primary thing that I want you to take away from this example is that really the way to think about mechanisms is that they're causal processes that take place through which actions that you're doing in the world, whether that is applying an intervention to some kind of a behavior change problem, or in this particular case, providing an implementation strategy. Those causal processes are the things that actually lead to the outcomes that you're trying to achieve, right? And knowing something about what mechanisms are at play is utterly practical. And I think this is really a key thing that I want you to take away from this, is because what that allows you to do is come up with other alternatives that might be acting through the same mechanism to achieve the same goal, right? So in our case of toast, you might be able to put a piece of bread in a skillet. You might be able to use a toaster oven. You might be able to use a griddle, and so on. All of these things share the same mechanism, that they're actually really hot surfaces, and you end up with transfer of heat to the surface of bread, right? Third, and this I think is really crucial, because people often get scared when they start thinking about mechanisms, is that the level at which you need to conceptualize a mechanism is really a function of what it is that you're trying to do, right? So in our case of this example of toast, what you don't need to do is figure out all the biochemistry and food biochemistry about how exactly the toasting works, right? That's not the level of analysis that you're working with. All you need to do is to figure out that it's really that something happens when bread is put in contact with very hot surface that creates toast, and that is good enough to give you a range of other options that you might be able to make toast, right? And so you don't need a PhD in physics, you don't need a PhD in psychology, whatever else, to start thinking about mechanisms, which frees you up to really start being thoughtful about how implementation strategies you are considering might work. And finally, and I think this is really, really important, that once you actually make a hypothesis about how you think something works explicit, then you can continue to revise it, right? You can actually try it, see whether it works the way that you intended it to work, revise the hypothesis. The field as a whole might start to revise those hypotheses as well, and I'll be coming back to that later in the talk. And so that allows the science to move forward, and for these accounts of how implementation strategies work to get refined over time. So how does all of this apply to implementation science or implementation of interventions, right? And so what I want to suggest is that if simple diagrams like these, and we're calling these causal pathway diagrams, or CPDs for short, are ways to allow you to very practically think about mechanisms in the context of implementation or in the context of intervention development, to get a sense of whether that implementation strategy has any chance of influencing the barriers that you're trying to resolve. And to give you a sense of that, let's start with an example. So before that, just so to give you a little bit more sense about causal pathway diagrams, These are really just adaptations of directed acyclic graphs, right? Which that try to use nodes and edges to create an account of how causal influence within a system takes place, right? And what we do with these diagrams is that we try to make very explicit the role that each one of these nodes plays in the process through which a strategy operates, right? So that's one of the innovations here, is that you're very, very explicit, and you'll be seeing that in a second, what exactly each node in this process is doing, right? And you can just think of these things as practical tools for decision making that can help you answer questions like, is it plausible for this strategy to resolve a targeted barrier? What must be in place for the strategy to actually work? What you might want to measure in order to understand variation in how well the strategy operates, and what are the sort of the earliest signs that you can detect that might tell you whether your implementation initiative is working as intended. So, and then finally, these tools can also be used as to allow you to theorize about how implementation strategies work. And both Byron and I are currently engaged in a project that's trying to do that for 30 most commonly used strategies in the field. So let's look at an example of how this might work. So what we know is that depression screening in primary care can be really useful for both early detection of depression as well as for increasing the referrals to behavioral health services, all of which, of course, if done consistently, should lead to better mental health outcomes. But we also know that getting clinicians to systematically and consistently screen for depression in primary care might be difficult, right? And so the question is, can we use CPDs to try to understand what might be going on here and what one might be able to do to improve the situation? So the way that we design CPDs is that a core part of the CPD is what we're calling the stem, or a trunk of the CPD, that really is trying to outline that central process that is going to take place if the strategy that you've selected is actually able to resolve the barrier that is in place, and then how that should lead to the long-term outcomes. So often you might start with the clinical outcome that you're trying to achieve. In this case, that might be improved depression outcomes, right? But one of the fundamental premises of implementation science is to get to that clinical outcome, you might need to have some implementation outcomes first. In this particular case, you need to have sort of consistent rates of depression screening. And really often when we're thinking about implementation, the strategies that are being chosen are chosen in order to create those implementation outcomes that we think will then have downstream clinical outcomes. And then the question is of, how to get there. And often in the implementation initiatives, one of the first steps is to do formative work to identify and prioritize barriers that are present in a setting, that are standing in the way of those implementation outcomes being achieved, right? And so the selection of the strategies are going to be done in such a way to try to resolve all of those prioritized barriers. And so one of the things that might happen in our example of depression screening is that clinicians, especially in primary care where they're dealing with very short visits, often have really highly divided attention, right? They're trying to understand what is going on with the patient. They're trying to chart at the same time. They have 7 minutes to do all of this. And so the need to screen is not really at the forefront at their mind. And so then the question becomes, what kind of strategy can you use to address this problem, and how would you know, right? And so that strategy would be a good match. So this notional mechanism, as Byron was mentioning, is really, we're thinking of it as a fundamental way to try to make sure that the strategies that are being selected in a particular implementation initiative are actually good matches for the barriers that we're trying to resolve. And so one of the things that then you might be able to do is, if you resolve those barriers accurately, is to try to find what are sort of the early outcomes that would give you a signal that your implementation strategy is working as intended. And typically we refer to these as proximal outcomes or early outcomes, right? And then finally, what we're going to have in causal pathway diagrams is a set of contextual factors that might influence how well the strategy is working, right? And there are two kinds of factors that we've identified. One are preconditions, and you can basically think of these things as light switches, that if a precondition is present, the causal process is going to flow as intended. While if the precondition is absent, the place where that precondition exists and where it might not, if it's not found, it's going to break the causal process. And you'll see a couple of examples of that. The other one are this notion of moderators that we're all familiar with, which are basically the factors that either strengthen or weaken the relationship between two steps of the process, right? And so part of what we try to do with causal pathway diagrams is help people think through what those moderators and preconditions are, so we can get a sense of whether this particular strategy that is being considered is actually a good match for the setting where it's going to be deployed. So let's try to play this out a little bit more, right? So one question that becomes what strategy can you use to really deal with this notion of divided attention? And so you might decide that actually having a reminder in the EHR, a clinical reminder that pops up when the clinician first logs in for a particular patient, might be a good strategy. But then the question is, like, how do you know that this would actually be able to resolve the barrier of divided attention? And this is where sort of thinking through the mechanism really comes into play. And so you might decide that the mechanism that through which EHR reminders operate is to just bring to the forefront of the clinician's mind the need to screen for depression, right? So you can sort of think of this mechanism as really being about enhancing salience of the need to screen, right? So this is a psychological mechanism, an interpersonal mechanism, and it's really trying to deal with this fact that typically clinicians are preoccupied with other things, and this is not going to be at the forefront of their mind. So that sort of gives you a sense that the clinical reminder could be actually a potentially an effective method of dealing with this barrier. And then the question becomes, okay, so if this is working as intended, what would be the earliest thing that you would see as a sign that the barrier is being resolved? And in case that you might be able, if you're able to measure it somehow, there's something about sort of the intention to screen being formed in the clinician's mind that would be probably the earliest outcome. And then, of course, provision of a screening instrument might be sort of a slightly further proximal outcome that would be between intention to screen and the sort of rate of the depression screening in the whole organization going up. So then the next question is, like, for this to work, what are the things that might need to be in place, right? And this is the question about preconditions, right? And we can sort of think about at least two for this particular example that might come into play. One is just that the prompt itself is noticeable, right? So this really is a question of how the EHR reminder is designed, right? If it blends in with a bunch of other things that pop up on the clinician screen, or if it's gets covered by another window or something like that, then that particular prompt has no chance of working. And all of this other part of the process, is never going to get activated at all. So that's one kind of a precondition, right? But you can also have preconditions in other parts of the causal process. So further down here, we have this notion that the screener has to be available in the room, right? So even if the clinician sees the reminder, even if they decide to screen, if the forms are not stocked, they might not be able to screen, right? And so that's another place where potentially this causal chain might get broken. And then, of course, the next question is, like, what other kinds of factors might influence this process? And this is a question about moderators. And just like with preconditions, moderators as well can function at multiple stages of the process, right? So you might actually have a moderator at the start of the process, which has to do with habituation to prompts. And this is a well-known example in the literature. We often refer to it as the reminder fatigue, or where if clinicians are getting too many clinical reminders, if those reminders are all packed together as part of the same window, after a while they just stop noticing them and they just sort of dismiss those windows without ever reading them, right? So that's one kind of a moderator that might influence how effective EHR reminders are for resolving this problem. Another moderator might be more of an organizational level moderator, like clinic visit length. Like, so the shorter the clinic visit, it's the more the clinician has to pack into that short period of time, and something like depression screening might not raise to the top of the priority list, even if they think it is important, right? Because there's so little time. So that could be a kind of a thing that might influence to what extent this kind of strategy works, regardless of whether the actual sort of divided attention is being resolved, right? So even if that particular barrier is resolved, these other issues might come into play that would still make it difficult for clinicians to consistently provide depression screening. So now that you've seen sort of what these kinds of things look like, how do they actually help with decision making? So as I mentioned before, one of the sort of key thing that CPDs allow you to do is really they allow you to have a plausibility check on whether the strategy that you're considering has a chance of resolving the barrier. And so if you cannot have a plausible account of what are the steps that would take place between the application of the strategy and the barrier being resolved, that particular barrier, that particular strategy might not actually be a good match for the barrier, right? So it sort of gives you a very simple way to just mentally check in on whether the strategy at least has any hope of working, right? There are other things that can still come into play, but if you can come up with a plausible account of how exactly that strategy would work, and so think about something like, instead of an EHR reminder, having training as a strategy, right? It's not really clear how it would affect divided attention, and I'm not sure that I could come up with a convincing account of what the mechanism would be for training to address this barrier, right? So it gives you sort of a very simple way of checking what is actually going on and whether that strategy has any hope of working. Another thing that it does is that it really forces you to very carefully think about the other elements of the context that might come into play that can actually make the operation of that strategy difficult, right? And so in our case, we identify two preconditions. And so if you have something like screening forms, like if the screening is being done on paper, if the availability of the screening forms is a requirement for this whole process to work, that might tell you about other things that might need to be put in place, such as like restocking procedures to make sure that those screeners are available at the point of care. The other thing that it might allow you to do is to identify moderators, right? And so and you can do that both in order to be able to address those moderators, right? So in the case of habituation, that the addressing of that moderator might have to do with how the EHR reminders are actually designed, right? So you might want to redesign how the reminder appears in order to deal with that moderator. Or you might be able to at least measure them and to see whether any differences in the effectiveness of the strategies can be explained by the differences in some of these other contextual factors, right? So it points you towards the things that you might need to measure within your initiative. And finally, it gives you a sense of the chain of the early outcomes that you would want to measure and observe, so you can do early course correction, right? So if you're not seeing your early outcomes for the barrier being resolved, that might be a sign that either the strategies are mismatched to the barriers, or that there are additional preconditions or moderators that are making that process not work effectively that you did not identify early on. And so as part of formative evaluations, it is really important to try to identify what proximal outcomes are going to be visible early on that would give you a sense of whether the initiative is working as intended. So you're not waiting 6 months or a year or whatever it might be to actually understand that your initiative is failing. So those are some of the basic things that CPDs do in the context of planning and evaluating implementation initiatives. But there are a few other advantages of this method that make it a really good match for improving how the robustness and the efficiency of implementation strategies. So one of them is just to allow you to make sure that all of the prioritized barriers are being covered. So one of the things that we often do is that we suggest that CPDs, given that they're intended to be really quick and simple to make, are created for all of the various barriers that have been prioritized. And so you make sure that you have at least one strategy which is addressing each of the barriers that you're prioritizing. It also allows you to optimize the package, right? So it might be that you have a set of strategies that you're considering, and when you do your CPDs, you realize that 3 out of 5 of those things are actually addressing the same barrier. And so you might then be able to think about whether all of those three strategies are needed, or whether you can reduce their number to ones that are most likely to be most effective for that particular barrier. You can also sequence activities, right? So you're able. So one of the things that we saw is that one of the advantages of CPDs is that it identifies these preconditions and moderators that might be in play for a particular strategy. And if you find one that needs to be addressed for a strategy that you want to include to be effective, that might indicate that there is another implementation strategy or some other kind of action, like restocking, that needs to be put in place first for that strategy to be able to work. So by outlining what all of the strategies, how all of the strategies that you're considering are going to be working, you can find out those touch points where strategies can either connect to each other to support each other, or you might be able to see that there's some inefficiencies in the list that you initially used that might allow you to remove some strategies and to make the overall strategy package more efficient. And so this is one example of what that might look like. So this is the work that was done with a digital mental health company called Oppo that Mike Pullman and Rosemary Mesa, the collaborators from UW and Kaiser Permanente, did, where they went through this process with Oppo on trying to understand how they might be able to increase the engagement with their digital mental health services. And one of the things that they found is that 2 implementation strategies ended up being able to resolve 5 of the barriers that Oppo was dealing with. So they could really drastically reduce the number of implementation strategies that they were considering using just by mapping out how the space works and seeing these connections between the strategies and the barriers that they're intended to resolve. Another thing that we are doing with CPDs, and I alluded to this a little bit earlier, is that we're trying to now articulate testable accounts of how commonly used strategies work. And so what you see on the screen here is one example of that. This is an account of how practice facilitation works that Brian Weiner developed. But both Byron and I are engaged in a project where we're trying to do this for about 30 strategies that have been commonly used in implementation science, to offer these accounts to the field so they can be refined and revised. It turns out that not many implementation strategies have rigorous theoretical accounts right now, and we're thinking that providing these kinds of clear accounts of how these strategies work will allow the field to refine them over time and really increase the robustness of our understanding of strategy functioning. And finally, and I find this particularly exciting, is that one of the things that we might be able to do with CPDs is really change how we think about the evidence in implementation science, right? Because if you think about what CPDs really are, they're really hypotheses about how strategies operate. And they're intended to be made for particular operationalizations of each strategy. So only in this place of theory building are we really trying to do this at the level of generic strategies, things like practice facilitation or audit and feedback. But usually when you're doing this for specific initiatives, you would want to create CPDs for particular operationalizations, concrete versions of the strategy that you're trying to implement, right? And so as people start doing that, we can start seeing how different operationalizations of the same strategy type are working, whether they have the similar kinds of moderators and preconditions, whether the mechanisms for differential personalizations are the same or different, which would help us really understand sort of what are the key decision points in how these strategies need to be designed to make them really well suited for a particular clinical setting. And so by really making these aspects of the strategy functioning explicit, and trying to understand how they would work in a particular setting by articulating the mechanisms and preconditions as well as that full causal chain, we can start to really understand the variations in both effectiveness as well as the processes through which these strategies operate, so we can get a better sense of whether things that we were calling the same name are actually different strategies, or if particular variations of the strategies require different contextual preconditions for them to work effectively. And what we're trying to do to try to systematize this kind of evidence is create a database that will be publicly accessible that would allow us to really put into the database the different implementation projects by breaking down what was done along the lines of these the entities that are needed for causal pathway diagrams. And so just to summarize this, and then that gives us a few minutes for discussion, We think that using either CPDs or some other kind of graphical tool like mechanism mapping is really helpful to help us think about the processes through which a strategy should be resolving the barrier, which would help you to better match strategies to barrier. They act as feasibility checks on whether a particular strategy is a good match for a particular context, as well as to ensure that all the necessary conditions for a strategy to work effectively are in place. And so although they're quite simple to create, these tools can be really effective at helping you play through how the particular set of implementation strategies that you're considering should work, and to ensure that there are no large unexpected factors that would derail how your implementation initiative works. This is a work that I've been doing over the last few years with a number of people. Byron is one of them. These are the collaborators that we have been working on this project with. And I just want you to just note that we have developed a comprehensive toolkit on how to use causal pathway diagrams in implementation science that is available from our website, and everyone is encouraged to download it. But also, as I mentioned briefly at the beginning, we're starting to use these tools out in mobile health as well. So not just from implementation, but really to think carefully about how different variations in the design of mobile health interventions are leading to the differences in their effectiveness. And I gave a talk recently for David Moore's and Andrea Graham's CBIT Center at Northwestern. And so there is a link to that talk on that topic, that if anyone is interested in hearing more about that. And of course, I'm more than happy to talk to you in person about it as well.